I just know you're going to love the guests that we have on in this episode, so don't go away. Welcome back to the interview. I'm Dr. Rick Wadge, and this is part 2 of a special series we're doing on hemochromatosis, and we're recommending the Iron Disorders Institute Guide to Hemochromatosis. You can pick this up on irondisorders.org. As special guests, we have Donna Wadge, who is a RN, and also a person who has struggled most of her life in learning to live with hemochromatosis. This is National Hemochromatosis Month. So you're going to be learning a lot about a disorder that you may not have even ever heard of before. As our special guest and expert, we have the co-founder of the Iron Disorders Institute, Cheryl Garrison. Hello, Cheryl.
Hello.
Thank you for being back with us for this second segment, and let's get right into it. Now, we've been talking about the need for people to understand all the different symptoms that may be leading up to them discovering they have hemochromatosis. Let's talk about some of that. Also, some of the nightmares that can take place when you self-diagnose. So there you go.
Well, the cover of the book has a lot of the symptoms written on it. As a matter of fact, when that book was published, Barnes & Noble put it up front, and people would pick it up for the symptoms. But the symptoms are critical. They're very, very important, and they can be key. But often when symptoms occur, some organ damage may not be reversible. So we want people to get those iron tests and know the results of those before they get symptomatic. A ferritin of 1,000 can be irreversible organ damage. And unfortunately, a lot of people in the medical community are looking at that as the cap point before they start treatment.
Now, when you start talking about the signs, I know because of my wife that these are something that she lives with every single day. Let's go through the list quickly. Chronic fatigue, joint pain, heart arrhythmia, chest pain, heart attack, skin color changes, that's interesting, diabetes, abdominal pain, and the list is long. How would a person know they have hemochromatosis and not something else?
Well, they can get a genetic test, but that isn't always fail-safe because there are so many combinations of genetics that you can have iron overload, you can have hemochromatosis and not have the standard combination of tests. So that's why we encourage patients to ask their doctor to do the full iron panel, which is fasting serum iron, serum ferritin, total iron binding capacity, and hemoglobin. With those 4, a physician can determine which iron disorder the patient has.
Okay. Now, I noticed that one of the books that my wife has brought in from the Disorder Institute, Iron Disorder Institute, is the Hemochromatosis Cookbook. Why is dietary understanding so important? Donna, you want to talk about that?
Well, the foods that we consume today, there's so much fortifying added to the foods, especially cereal. One of them was my favorite, and when I looked at it after I was diagnosed, it had 90% fortification placed in it. Breads, of iron, yes, of iron, 90%. And I encourage everyone, take a look at what you're eating because there's so much fortification, so many things that are put in and added to breads.
Well, girls, I remember when I was growing up as just a kid, that was one of the things that my mother looked for on the boxes of cereal. She wanted me to have added iron. What if I had had hemochromatosis? So how does a person know? By looking at the back of the box, understanding what it is, but they first need to know that they don't need the extra iron. Is that correct?
Correct. Correct. Our bodies they're beautifully made, and normal metabolism will get the iron we need. In fact, women who get pregnant actually increase their absorption up to 30 times what they normally would take in, because the body knows it needs that extra iron for that developing child. And so we also slough off what we don't need, except if you have hemochromatosis. You can't get rid of the extra iron. You have to actually have it removed by blood donation, phlebotomy, which is a prescription blood donation, or in some rare cases, iron chelation with a specially formulated pharmaceutical product.
Cheryl, would you share a little bit about the uptake of iron in the foods that we eat?
Right. Well, like I said, normally we absorb about 1 milligram of iron, which is what we normally slough off in skin cells and perspiration and so forth in the day. And when that iron gets into the stomach, into the gut, it has to be changed into a form that's better absorbed. And so things can interfere with the absorption. And that would be, like, for example, very common, the proton pump inhibitors, which are given for gastric reflux. Those will totally block iron from being absorbed. Whereas vitamin C, and this is usually supplemental vitamin C, that will increase the absorption of iron. So you look for foods and substances that either enhance or increase, and you work accordingly. If you have hemochromatosis, iron overload, you want to be consuming those things that are going to block iron. If you have iron deficiency, you're going to be wanting to take in those things that increase the absorption of iron.
Mm-hmm. And again, this cookbook that is put out by the Iron Disorders Institute does go into some of the ways that the heme iron and foods that you eat, as well as this book, how the iron is absorbed in the body, what to look for, what to watch for, what to intake and what not to intake to help limit that absorption.
Right, Donna. And essentially we consume 2 forms of iron. Heme, which is, or some people call it heme, that's HEME. That is, that has protein. It actually has the animal blood in it. The non-heme, which is plant-based, both of those types of iron can be taken in. Heme iron, which you get in red meat, such as beef, venison, dark meat of turkey, chicken, and so forth, and some fish. That one can be easily absorbed by the body because it's ready to take in. Whereas plant-based iron is not so easily absorbed, and it can be blocked, quite frankly, with coffee, tea, chocolate, calcium, and there are various things that can block the absorption of iron. Now, we have a list of all these foods on the Iron Disorders Institute website. They just click the button on diet, and it'll take them right to whichever diet they're looking for, to replenish iron or to deplete iron.
One of the things that I just wanted to share and touch on was at the time prior to me being diagnosed with the hemochromatosis, I would eat shellfish and other foods that I had no clue to how detrimental they were to my health. And I started developing allergies to it and getting sicker when I would eat them. And I thought it was just because I was allergic to them. And as I started reading them, in reality, I realized that they could cause immediate death within hours.
Absolutely. In fact, we think that some of the deaths in Katrina were septicemia caused by the exposure to Vibrio venophthis. Sorry, that's a mouthful. Vibrio for short. It's a bacteria that can be in raw shellfish. So anyone with high iron, especially a high saturation percentage, should avoid raw shellfish. That would be oysters, any of the sushi, raw fish, because they can be contaminated with this bacteria. It's not harmful to everybody, but it is harmful to those with really, really high iron.
Okay, so one of the things that we want to bring up again is it's so important that you see your doctor and find out if you have an iron disorder. A self-diagnosing can cause huge problems. And off camera, Cheryl, you mentioned a couple of cases. Would you like to bring those up?
Yeah, yes, indeed. We had a gentleman, these were in the early years, who suspected that he had hemochromatosis, and he did his own phlebotomies without the benefit of a physician. And it is critical that a hemoglobin be checked before a phlebotomy is done. You literally could kill yourself. This man went on. I don't know the outcome, but I know he made himself very, very ill. The patient-physician relationship is critical because they teach each other, and the physicians learn through the patients, especially with this condition, because it is not well understood. As Donna has said before, years ago, it was an old man's disease. It didn't happen in women. We know differently now. So physicians, we find, are hungry for this information. They're happy to know about it. And they're also very glad to get an educated patient, not someone who's, banging the shoe on the desk or whatever, demanding whatever. If a patient is well educated and knowledgeable, they can walk into a physician's office and make sense and help one another. And that really takes me back to the time when my son almost died of a juvenile hemochromatosis form. And the doctor who helped me said, well, Cheryl, David has elevated sugar but he had wildly elevated serum iron. And I didn't know anything about iron except that I had a bottle of liquid iron in my cabinet for fatigue, which was given to me. So this physician, God bless him, because he did the test, he found out what was going on, and I was able to get David's iron levels down. And he is a healthy, happy 37-year-old right now on his way to Thailand.
Cheryl, how old was he at that time?
Pardon?
How old was he at that time?
David was probably 15, and so the symptoms that he was having were chronic fatigue. Remember the discoloration? His skin was actually turning an ashen gray green. He was very tired. He had an enlarged spleen, so he had the abdominal pain, joint pain, headaches, and he would fall asleep on his desk at school, and they would call me and say, please come and get Dave, he's not well. The first doctor I took him to said, all teenagers are lazy, he'll outgrow it. And I looked at that doctor and I said, I know my son. He is a happy, well-balanced, pleasant individual. And that's not how he is right now. I know he's ill, and I've got to find out what's going on. And so that was my reason for starting my journey to discover iron and iron overload. All I had at that time was the Merck manual. It said it was fatal. And I sat there, I can remember to this day, sitting there in the living room crying with that Merck manual in my lap, thinking, my only child, I'm going to lose my only child. Well, that wasn't the outcome. So thanks to a lot of people along the way who got the answers, and I'm so grateful to them. And grateful to you all for doing this. This is wonderful. I understand you go all over the world.
Well, we do, and we're honored to have you on. And, that brings up a very good and significant point. And that is, we're filming this in the United States, the Western world. What about the Eastern world? How do they struggle? Is it different with their dietary intake? And is there more or less symptoms regarding hemochromatosis in the Eastern world?
I'm going to say that the manifestation of the consequences of too much iron can vary depending on the ethnicity. In fact, a very important point is, like, for example, in Blacks, they can handle a hemoglobin around 10, where Caucasians need a hemoglobin around 12.5. So there are disparities, there are differences. And Dr. Leo Zakarsky, one of our medical advisors, and actually he is He and Dr. Gene Weinberg are my oversight. They keep me on track and on point. Dr. Zakarsky writes about these disparities, and we will be publishing his works in our ID Insight medical journal, which we hope to have rolled out this year, if not in 2018, 2019. So some of those really good articles for physicians will be available as in a medical journal format.
You know, I read, Cheryl, in whether it be biblical times, things about bloodletting, articles regarding George Washington and Ernest Hemingway, and different articles over time and doing some research. Regarding the iron, do you think there's some connection between the chemical imbalances of the iron that goes to the brain?
Oh, yes. And I'll tell you something interesting, Donna. Dr. Zakarsky sent me a whole string of biblical references to iron and diet and so forth. And I think I may have shared those. If I haven't, I will look those up and send those to you because they're fascinating. Sure. And yes, the medical doctors knew some time ago that the phlebotomy had health benefits to it. And so leeches were used and bloodletting. And I think there were some deaths because they overdid it. And that's what we try to warn people, don't overdo it. That's why don't self-diagnose, don't self-treat. Please make friends with your physician, because if you educate one physician about this condition, that physician will reach 100 people in his or her practice.
Okay, I'm thinking about diagnoses that people have received, but possibly they've been wrongly diagnosed, and ultimately it could be hemochromatosis. What are some of those diagnoses that people have received that could be incorrect?
Well, better said, most of the people will be diagnosed with a consequence of hemochromatosis, like
exactly.
Diabetes or heart failure or liver cirrhosis or hypothyroidism or hypogonadism, and the practitioner will stop there. They won't go to the underlying cause and correct that. So the individual gets on a merry-go-round of this disease, that disease, this disease, and some actually develop such a deep depression that they will commit suicide. And I hate to tell you that, but that is the case. It's rare, but we have heard of people being so despondent, waiting for a diagnosis. I think Chris Kiefer, one of my colleagues and also co-founder of Iron Disorders Institute, says in most diseases you wait for a cure. With hemochromatosis, you wait for a diagnosis.
I have to share with you, when I was diagnosed, I printed out all of the materials at a Thanksgiving dinner and handed it to all of my family members that were present, and there was probably at least 30 or 40. And I never expected, but one that was the oldest living cousin that I have, we started up a conversation prior to that. How you doing? What you been doing? I've been having phlebotomy, and never knowing that he would have been the one that would be the most receptive out of all of them. However, when I gave him one of the cards from the Iron Institute, he went back and gave it to his doctor, and he was misdiagnosed with polycythemia. And they retested him, and he called me and he says, how'd you know all this? My doctor wanted to know, And so, I led them to the Iron Disorders Institute so that they could obtain additional information. But that's, just one simple example. Instead of the polycythemia, he had the two genes as well.
Right, and polycythemia vera is, that's not an iron disorder as much as it is a blood disorder. Men who have hemochromatosis and hypogonadism, who are on testosterone replacement, sometimes can develop polycythemia vera. The part of the treatment is phlebotomy as well, so it can get the lines can get blurred there in the diagnosis. That's good, Don. That's an excellent point.
I'm thinking of a practical example we have before Donna and myself right now, and that is our son-in-law, Jason. Now, Jason, strong young man. We both have similar backgrounds of working in the trades prior to going into ministry and in television. But strong young man, seemed very healthy. What were some of the symptoms he was dealing with prior to finding out he actually has hemochromatosis?
Extreme fatigue as well, joint pain, but him again being not even 30 yet, but the fatigue and the joint pain, and he was just powering through it, thinking because he worked so many hours and different things, being a family man and going, but diagnosis is never what you want, but at least it's something that you kind of get and go, okay, it's not all in my head. This is something real. I can deal with it and learn to live with it.
And one of the things, and I'll finish with this on my end about Jason, is that he said, I remember hearing him say this, I thought it was normal just to be in pain.
Mm-hmm. Mm-hmm. That's a good point. Yes, a very good point. And here's another one. Sometimes when physicians are aware and they do the genetic test, they will be different in their approach to therapy. Like, for example, a young person was diagnosed genetically, and the physician was overzealous with the phlebotomies and actually made this young person iron deficient. And on the other extreme, some physicians will look at the level of ferritin and be comfortable with it up to 1,000, that's a critical zone. You want that ferritin lower than that if possible. And so the word out there right now is we don't have to worry about it until the ferritin reaches 1,000. That is not correct. And if we can spread the word to check a ferritin, save a life, that will help get a diagnosis or at least a look at that ferritin level. And then we tell them, if it's reaching 1,000, do something now. And that's where the patient has to really take charge of themselves. Like you said earlier, Donna, they have to be proactive. Don't cut your doctor out, but be proactive and know your iron levels first, know what to do to get them in balance, and then take action to make that happen. And that is always with the doctor at hand.
Something that I find that is extremely important and that I share with everyone, that if they're sharing with their provider and the provider does go to actually genetically test, when the lab work comes back, my daughter had the same situation 3 different times, coming back and just showing her a number, a ferritin level or an iron level. And I share with everyone, it's not going to be just a lab value. You're going to have a paper that's written out and it's going to explain the gene you have, da, 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 da. I find that in many cases, when the patients have been told that they've ran that test, they'll come back and say, well, this is my number. It's not going to be just a number. Would you agree?
Donna, that is good. I love the way the health records are done now, where everybody can go into a health vault and see things, because that's one of the things we tell patients. Please know your numbers and keep copies of your work. And so with the health vault, they can actually go in there and read those numbers off. And that's what we have to work with. What are your levels and how far are they out of range? We actually will work with patients in a I'm going to call it a relationship of iron educator, which I am, and the patient advocate, who is usually a spouse, and then the physician. And together we look at those iron levels, make recommendations through letters to the patient that they share with their physician, and this is how they get their iron back in balance, working together.
Ladies, this has been a fast half-hour segment dealing with hemochromatosis. So one of the things that we certainly want to talk about and leave you with is the Iron Disorders Institute Guide to Hemochromatosis. You can pick that up at irondisorders.org. And Cheryl Garrison, you have been the co-founder and director of the Iron Disorders Institute. Thank you for enlightening people to a disorder that most people have never heard of before. And thank you for being on ITVN and discussing something that is so vital right now to the world's health.
And Rick, thank you for doing this. This is terrific. We really appreciate it.
Glad to do it. And Donna, thank you so much for not only being a nurse who has extensive research been done on hemochromatosis, but also you've struggled with it your whole life, and you can help other people understand what to do and how to live with this. Thank you, ladies. Appreciate it. We appreciate you at ITVN. Thank you so much for, again, watching the interview. And this whole month that we're actually filming this, we're going to be discussing different medical disorders and how you can be healthy in body, soul, and mind. We'll see you next week. Shalom, shalom.